Hello everyone, this is Bayan Al-Zumaili and today we're talking about peptic ulcer disease. So this is the outline that we are going to follow. I will start talking about the anatomy of the stomach and the small intestine. Then we will move on to the histology, the gastric mucosa and the small intestine mucosa. Then I will talk about the physiology of acid secretion and regulation. Then we will move on to the mucosal protection, and the last objective is the peptic ulcer, and this is the most important part. I will give you an overview, we will talk about the causes and pathophysiology, then I will move on to the presentation, management, and complications. So this is a brief overview of the anatomy. This is the stomach. It is divided into 4 different parts. The first part is the cardiac part. It's the part of the stomach closer to the lower esophageal sphincter. And then we have the fundus. The fundus is when you draw a horizontal line going from the lower esophageal sphincter, the part of the stomach above it is the fundus. Then we have the body, and then we have the pyloric region. Of course, after the pyloric region, we have the pyloric sphincter. After that, we start going into the small intestine. So if I draw a continuation here, okay, so this is the duodenum, the first part of the intestine. And then we have the duodenum and the ileum. The duodenum is divided into different parts. The first is the duodenal cap. Then we have the descending, the transverse, and the ascending parts. Okay, so starting with the histology. The histology of the GI tract is divided into 4 different layers throughout the GI tract: the mucosa, the submucosa, the muscularis externa, and another layer here called the serosa. So these are the 4 different layers. The layer that we are interested in is the mucosa. So the mucosa, as you can see in this slide, is actually in the stomach. This is why it has these folds. These are called rugae. Okay, so the mucosa is also divided into different parts: the epithelium, the lamina propria, and the muscularis mucosa. Do not confuse muscularis mucosa with muscularis externa. Muscularis mucosa is a part of the mucosa. It is directly beneath a very thin layer of muscle, directly beneath the mucosa, while the muscularis externa is a different part on its own. Okay, so these are the different parts of the mucosa. And here you can see this is the gastric pit. You can see here where the gastric pit ends, we have the beginning of the glands, and this is the gland tubule. It is divided into different parts: the isthmus, the neck, and the base, and these parts are important for us in order to know where each type of cell is located where exactly. Okay, so I'll start talking about the different types of cells, then I will explain where each cell is located where in the different parts of the stomach. So first of all, the parietal cells. Now the parietal cells are the cells that produce hydrochloric acid, and these type of cells, where they are located in the gland tubule, is the neck. So they are present in about this region. This is where we can find the parietal cells secreting hydrochloric acid. The second type is the chief cells. So chief cells, they are present in the body. So they are in the lower body or in the base here. So body, and they produce pepsinogen. They produce pepsinogen, which is later on converted into pepsin that can digest proteins. That's why it's important for us that they are present in the base or the body of the gland, because when we have production of pepsinogen, pepsinogen can go all the way up here before it gets activated by the low pH or hydrochloric acid. Okay. Third type of cell is the endocrine cells. So the endocrine cells are actually divided into 2 different types of cells: the D cells and the G cells. The D cells, they produce somatostatin, okay? And this somatostatin gives the negative feedback for us to stop hydrochloric acid. That's why it's important. G cells produce gastrin, which does the exact opposite. Gastrin tells us to produce more hydrochloric acid. Okay, then we have 2 additional types of cells. So we have the ECL cells, or the enterochromaffin-like cells. The enterochromaffin-like cells produce histamine, and this is also another important regulator for the acid secretion. And we have a 5th type, which is just a different type of cells that produce mucus. So these are the mucus neck cells present in the neck of the gland tubule. Okay, so the glands are distributed according to the regions that we discussed before. The cardiac region has mainly mucus producing cells. So what's important is the fundus and the body. The fundus and the body, or the corpus, this is the part of the stomach, or these 2 parts are where all the other types that we discussed before are present. So we have the parietal cells, we have the chief cells, we have the mucous neck cells, we have the endocrine cells, we have the ECL cells, we have everything in these, in the fundus and the body. And then we have the pyloric region. The pyloric region mainly has an abundance of G cells, doesn't have a lot of parietal cells, and that makes sense because we do not want to produce a lot of acid before we go into the duodenum, and then we don't have any chief cells present in the pyloric region. Okay, so this is just a table that shows you the cell type and where it is present and its function. Just a table for you to go over. Okay, so the third objective, physiology of acid secretion and regulation. We have discussed before that acid is secreted by the parietal cells, okay? So parietal cells get positive feedback and negative feedback. Positive feedback mainly comes from ACH, which is the parasympathetic supply, the vagus nerve, and then we also have gastrin, produced by the G cells, and we have histamine. All these give the parietal cells positive feedback to produce more hydrochloric acid. Parietal cells get negative feedback from somatostatin. Also, it gets negative feedback from prostaglandins, and if we have a very low pH, this also gives us negative feedback for the parietal cells not to produce more hydrochloric acid. Okay, so what happens when you have food? When there's food, when the person sees or smells or tastes food, you have vagal nerve stimulation. Vagal nerve stimulation, what does it do? Well, we have the vagal nerve stimulation producing ACH going all the way to the D cells and stops somatostatin from being produced. We don't want to stop hydrochloric acid because we know there's food coming and we want hydrochloric acid to be there to digest that food. Okay, and then we have stimulation of the ECL cells also by ACH. ECL cells produce histamine as we've discussed before, and histamine gives positive feedback for the parietal cells to produce more hydrochloric acid. Okay, also the vagal nerve stimulation can go directly to the parietal cells and tell them to produce hydrochloric acid. So when the food reaches the stomach, we have the distension of the stomach. The distension of the stomach triggers two things. Distension of the stomach triggers gastrin to be produced from G cells and the ECL cells also to produce histamine. Gastrin and histamine both go to the parietal cells and tells it to produce more hydrochloric acid. In addition to that, gastrin goes to the ECL cell and tells it to produce histamine, which will later on tell the stomach to produce more hydrochloric acid. Okay, so this is for distension. Also, if we have peptides, small peptides tell the G cells to produce gastrin, which also tells the parietal cells to produce more hydrochloric acid. Okay? So what we discussed is the phases of the gastric acid secretion. Now we just need to put the names. Moving on to the fourth objective, mechanisms of mucosal protection. Now the mucosa of both the stomach and the intestine have to be protected against what's going on in the lumen. We have hydrochloric acid, and we have digestive enzymes that might damage our cells. That's why we have mucosal protection. So the first mechanism is acid production regulation. We talked about the acid production and how it happens, what's positive, what gives it positive feedback to get produced, and what gives it negative feedback not to get produced. So hydrochloric acid regulation is very important. We also have to remember that when we have low pH, we stop hydrochloric acid production, and when we have some gastric content, we want to produce hydrochloric acid for that gastric content to get digested. So acid production and acid production regulation is important. The second mechanism is mucosal barrier. Now the mucosa has a barrier. First, it has an apical membrane resistance. So if we draw the cells in the stomach, this is the apex, this part is the apex, and it is very resistant to whatever is going on in the lumen. The problem is that this resistance is only at this surface, the apical surface. It is not present anywhere else. That's why it's very important that the cells have very strong tight junctions, and they also have mucin. That's basically a layer that's above them and does not allow things to go inside. And also it has gastric surfactant. Gastric surfactant is also resistant to any charged molecules to go through it. So we have this layer of thick mucus over them, and they themselves on their apical surface are very resistant to acid or any digestive enzymes. So this is the mucosal barrier that we have. And then we have epithelial repair. Epithelial repair is very important because This acidic environment can easily damage our cells, and when we have any small damage, we have very acute and fast repair. First, we have hyperemic response when we have the damage. This causes dilation of vessels. When we have dilation of vessels, we have a lot of blood going to that injured area. This blood going to that injured area provides that area with a lot of fluid that can help in formation of a mucoid cap. So if we have, let's say this is a small injury here, first we have a lot of blood going there, and this blood would help us in having a lot of fluid going out and helping in producing this mucoid cap. This mucoid cap is very thick, doesn't allow any substances to go through it, and when we have this mucoid cap, the epithelial cells can easily migrate to that part and cover it up, and we have the repair of this injured part. Okay, so moving on to our fifth objective, peptic ulcer disease. So what is peptic ulcer? It is any damage or erosion of the mucosa of the stomach or duodenum and sometimes the esophagus. This erosion or damage has to be deep enough to go into all the way to the muscularis mucosa. Okay, so peptic ulcer can be either acute or chronic. Chronic peptic ulcer occurs mostly in the upper GI, and this is the most common type of peptic ulcers. Okay, so we have two main types of peptic ulcers according to the region. We have gastric ulcers and we have duodenal ulcers. Gastric ulcers male to female ratio is about 2:1, while duodenal ulcers male to female ratio is 5:1 to 2:1. So duodenal ulcers occur more in male than they do in female, and in general duodenal ulcers do occur 3 to 2 times more than gastric ulcers do. Gastric ulcers, 70% of them occur because of H. pylori, but duodenal ulcers, 90% of them occur because of H. pylori infection. Okay, so common causes of peptic ulcer include smoking, NSAIDs or non-steroidal anti-inflammatory drugs, also H. pylori, which is actually the most important here, and some other causes including hyperacidity and Zollinger-Ellison syndrome. I'm not sure if I'm saying it right, but Zollinger-Ellison syndrome happens because of pancreatic adenomas that secrete gastrin, and when they secrete gastrin, they cause hyperacidity that causes this peptic ulcer, and a list of other causes. So talking about NSAIDs, how they can cause peptic ulcer, well, first of all, in this diagram, you can see that these are the pathways of COX-1 and COX-2. What NSAIDs do, one of the things that they do is that they inhibit COX-1 and COX-2. Now, the new selective NSAIDs only work on COX-2, but non-selective NSAIDs work on both. The problem is when they work on COX-1, what happens is they can affect the gut mucosal integrity. In addition to that, NSAIDs can also cause inhibition of prostaglandin H synthase, and we've talked about prostaglandin before. Prostaglandin can be one of the mechanisms to reduce hydrochloric acid excretion by the parietal cells. Okay, but evidence shows that only 20% of people on NSAIDs have been found to have peptic ulcer. But NSAIDs do have an increased risk of bleeding and perforation in pre-existing ulcers. Okay, so moving on to the most important cause of peptic ulcers, which is H. pylori. H. pylori are gram-negative bacilli that are spiral in shape, and they have flagella. You can see these flagella here. So these flagella are actually very important in helping these H. pylori reach and dig through the mucous lining of the stomach and the duodenum, and when they dig through, they get all the way to the surface of the epithelial cell lining that we have in the gastric mucosa or the duodenal mucosa. And when that happens, they have adhesion molecules called BAB-A these adhesion molecules, they actually bind to Lewis B antigens that are present on the epithelial cell surface, and this makes these H. pylori stick to the surface of these epithelial cells, and therefore they would have a very good environment that is not as acidic as the lumen of the gut. So now that they have a less acidic environment, to be even more sure that they can buffer the environment around them, they have an enzyme called urease. So urease is an enzyme that breaks urea into carbonic dioxide and ammonia. This ammonia helps the H. pylori to have an even less acidic environment around them, and therefore they can multiply and they can colonize. In addition to that, H. pylori have a toxin called VAC-A. It causes the gastric epithelial cells to form large vacuoles, and this makes these epithelial cells more permeable. In addition to that, it causes these epithelial cells to have an efflux of micronutrients, and in addition, they also cause induction of apoptosis and suppression of local immunity of these epithelial cells surrounding them. So this is about VAC-A. We also have a cytotoxin associated gene. Now this gene, when it's injected into the epithelial cells, what happens is that it interferes with numerous cell signaling pathways, and these cell signaling pathways have to do with cell replication and apoptosis, and this is also another way that H. pylori can cause destruction of the epithelial cell lining. And in addition to all of that, H. pylori cause gastritis with increased gastrin production. Now, when you have an increase in gastrin, what happens is you have activation of hydrochloric acid secretion from the parietal cells, and this causes hyperacidity, which can lead to even more damage of these exposed and inflamed epithelial cells. So how do duodenal ulcers occur? So first of all, we have depletion of antral D cell somatostatin. So when we don't have somatostatin that much, especially in the antrum, because H. pylori colonize mostly in the antrum of the stomach, so we have this depletion of the D cells and therefore depletion of the somatostatin. We have an increase in gastrin release as well, because H. pylori can also cause increase in gastrin release. Both these, inhibition of D and induction of G, this would cause increased acid secretion. This acid, of course, since all the food and chyme is actually going this way, we have increased acid load in the duodenum, and this causes later on gastric metaplasia. So we have gastric metaplasia, you have different patches of gastric mucosa in the duodenum, and this causes colonization of the H. pylori in the duodenum, and this causes further inflammation and ulceration. So patients with the peptic ulcers can present with any of these three dyspeptic symptom patterns. They can either present with ulcer-like or acid-like dyspepsia, food-provoked dyspepsia or indigestion, or reflux-like dyspepsia. For ulcer-like or acid-like dyspepsia, this is a burning pain that is epigastric and hunger-like and can be relieved with food, antacids, and any anti-secretory agents. This is the ulcer-like or acid dyspepsia. The second type of dyspepsia that the patient can come with is the food-provoked dyspepsia or indigestion. Food-provoked dyspepsia, this is a postprandial epigastric discomfort and feeling of fullness and early satiety and nausea and occasional vomiting. Patients who come with food-provoked dyspepsia are usually underweight, unlike patients who come with ulcer-like or acid-like dyspepsia. This is relieved with food, that's why they come with weight gain. The third is reflux-like dyspepsia. Now, a good number of patients can come to the clinic with no symptoms at all except for the change in the color of the stool. where the stool will look blackish in color, and this is called melena. So melena is basically when the patient has bleeding from the upper GI and the RBCs are already destroyed and they are already digested. That's why they give this stool this blackish color and darkening. So moving on to the diagnosis of peptic ulcer. With peptic ulcers, we would like to know and diagnose whether these dyspeptic symptoms are in this patient because of peptic ulcer disease. And even if we know that it is due to peptic ulcer disease, we would also want to find what is the cause of this peptic ulcer disease to help us later on in the management. So you can see here that the first thing I wrote was blood tests. Blood tests do not help in telling whether the patient has peptic ulcer disease or not. On the other hand, we can see from the complete blood count, the hemoglobin and the red blood cells count and all of that to see if the patient has any abnormalities in that, and we can see if the patient has anemia in order for us to see and look into the management later on. Now, the second test that we have is endoscopy. Endoscopy is actually the best diagnostic test for peptic ulcer disease. It has a very good sensitivity and it is the gold standard. Now, endoscopy is very important not only because it tells whether the patient has peptic ulcer disease or not, but it also helps in differentiating between the normal benign gastric ulcers, not normal, benign gastric ulcers from any cancerous lesions. Endoscopy can later on also help in the follow-up of the patient. If he has gastric ulcer or if he or she has gastric ulcer, then they have a high risk of malignancy, and this is how endoscopy is actually very important in these patients in their follow-up. Now, we also need to test for H. pylori, especially when an ulcer has been found. So H. pylori can be tested in two different ways, either invasive or non-invasive. If the diagnosis has already been established through an endoscopy, it is a very good idea to just take a biopsy of that lesion in order for it to be tested later on. Then this is actually the gold standard for diagnosis of H. pylori infection. We also mentioned that there are non-invasive methods to diagnose H. pylori infection and see if the patient has it or not. That can happen through the C-urea breath test or the fecal antigen test. The C-urea breath test is actually very good. It has high sensitivity and specificity. So before we move on to the management of peptic ulcer disease, this table is a very good table that compares gastric ulcers to duodenal ulcers. It has been done by one of our colleagues. Please go through this. Very important, very helpful indeed. So moving on to the management of peptic ulcer. So the management of peptic ulcer differs according to the cause of peptic ulcer. So if this ulcer was due to H. pylori, the management would be different from when it is caused by any other cause. So if the cause was H. pylori, it makes sense that we need to eradicate this H. pylori infection. And this happens with a treatment that includes 2 antibiotics and a proton pump inhibitor. I won't be talking much about the pharmacological management of peptic ulcer disease, and that's because a colleague of mine will do another video talking only about the management of peptic ulcer disease. Now, for peptic ulcer due to other causes like smoking, like NSAIDs, like any other cause, for smoking, it's better that the patient stops smoking because smoking also delays ulcer healing. Whether or not the smoking was the actual cause, it does delay the ulcer healing. Also, NSAIDs are most likely stopped, or if the patient has to take these NSAIDs, then the dose has to be regulated, and a specific regimen for that patient has to be developed. So as for the invasive management of peptic ulcer, a choice would be endoscopy therapy. Endoscopy therapy is usually done when the patient has perforation of the ulcer, and this perforation is causing a lot of bleeding, and the gastric secretions are going into the abdominal cavity. So this is an emergency and endoscopy therapy has to be done. Another way or invasive method is surgical management, and it also has indications that include when the peptic ulcer disease is refractory and it is not responding to medical management, and if there's any suspicion of malignancy. And it is also done for managing any peptic ulcer disease complications, including bleeding peptic ulcer, perforated peptic ulcer, gastric outlet obstruction, and a list of other complications. So this is a picture that shows endoscopy therapy. It actually shows endoscopy therapy using laser. There are other methods for endoscopy therapy to be done, but they are not really the scope of this video. So we have already started talking about the complications of peptic ulcer. These complications include bleeding, hematomesis, melena, or both. So the patient can present with vomiting that has blood in it, or blood in the stool. Another complication is the perforation. In this picture, you can see what is perforation. Perforation is when the gastric ulcer or when the duodenal ulcer goes all the way through all the layers, even through the serosa and out into the abdominal cavity. So this is perforation. Penetration, on the other hand, is when this ulcer is at a side where another organ is close to the stomach, most likely the liver, and it penetrates all the way through through all the layers of the stomach in this case, and going on all the way to the liver and causing ulcers in the liver itself. So this is penetration. We also can have gastric outlet obstruction, and this happens when the ulcer is healed, but it is not healed in a good way. It has healed with scar tissue, and this scar tissue would cause strictures, and these strictures would later on cause gastric outlet obstruction. Other complications include refractory ulcer disease and malignancy, especially if it was gastric ulcer.